Thank you very much for the introduction. I'm delighted to be part of this conference again with my colleagues at the Football Science Institute. And my presentation is going to be on biomechanical analysis after ACL reconstruction. Much of the data I will present is part of my work as head of performance at the Sports Surgery Clinic, and will share the expertise and insights from all of the multidisciplinary team and my colleagues at the Sports Surgery Clinic, from orthopedics to biomechanics, radiology and strength and conditioning, and much of the data that we've collected on elite and sub-elite and recreational athletes as they return from ACL injury and back to competitive sports. And the facilities that we have here in Dublin, looking at the ability to biomechanically analyse their recovery and chart their progress at 3 months and 6 months and 9 months post-surgery, and try and identify who has successful outcomes afterwards. The question very often for us though is, what is a successful outcome after ACL reconstruction? We've many different important facets to consider, such as, does the athlete return to play? Do they return to playing their best or return to performance? Have the ongoing knee symptoms and second injury? And obviously there's a whole host of factors in terms of their sport-specific skill and conditioning, psychological and social factors, and obviously their injury risk profile specific to them as an individual athlete, but also the healing and remodeling of the graft. However, I'm going to focus primarily on the top section here, which is the physical tests and the recovery of movement strategies post-ACL. So the one factor that most athletes are interested in, and indeed that goes for coaches and much of the elite team, backroom team, is they want to know, when is an athlete ready to return to play? And return to play rates after ACL reconstruction are quite high. And as you see from our colleagues here, Marcus Waldron, Martin Hagland, Henrik Magnussen, Jan Ekstrand, that almost 90% of elite footballers have returned to match and to competition by 10 months post-surgery, and a lot of them have returned by 8 months. So the return to play rates is quite high. However, there are a number of factors we need to consider. Some athletes do not return to their best, some have ongoing knee symptoms, and unfortunately some will go on to suffer second ACL injury. So perhaps return to play is not what we should be focusing on, but more asking ourselves, what does a fully rehabilitated athlete look like? What do we need to test for? What movements, what deficits are most common post-ACL reconstruction, either as a result of the injury and the surgery, or deficits that will leave them predisposed to having knee symptoms or ongoing issues leading to second injury. And so while most of our rehabilitation and the athlete's performance is built on the foundations of strength, explosiveness and reactive strength, we also want to be able to measure their jumping and landing mechanics, their running and acceleration mechanics, and their change direction mechanics, because it's this combination of physical qualities and movement strategies that will ultimately dictate how quickly an athlete can return to performance, but also how long they can remain performing at their best in the absence of ongoing issues or second ACL injury. So why do we need to consider 3D biomechanical analysis? We want to identify risk factors relating to poor outcome, to identify limitations to optimal athletic performance, to try and profile athletes individually to see where are they as an individual athlete along the stage of rehabilitation, and how can I begin to be more specific in their rehabilitation protocols, and ultimately to provide reliable and objective return to play decision making using the gold standard in movement analysis. Unfortunately, we know that ACL second injury can be quite common, especially in elite football, with almost 10% going on to rupture either their contralateral knee or 10% going on to rupture their previously operated knee. We know that the most common mechanisms of ACL injury in football are very often during pressing or tackling, during landing, very often after heading the ball, and returning to single leg balance after kicking. And we know that the primary role of the ACL is to constrain that anterior tibial translation of the tibia on the femur. Secondly is to control interior tibial rotation, and thirdly is to control knee valgus as a secondary restraint after the MCL. So again, these images we see here of an athlete pressing, a footballer pressing, where he's decelerating, a large posterior ground reaction force causing an anterior tibial translation, loss of center of mass control relative to the stance leg, and then the additional valgus motion, ultimately combining to end up with an ACL rupture. The question is, when we're looking at movement strategies, how much is too much? How much is too much valgus? Which one of the variables throughout the kinetic chain is the most important when resulting in ACL injury. We know that ACL injury is more common in female footballers than in male footballers, but again, our colleagues in Norway have looked at the biomechanical differences at the time of injury during basketball and found that female athletes tend to rupture their ACL in more hip and knee flexion and more knee valgus, which means obviously male athletes have less knee flexion and less knee valgus. So again, which variable is most important and how we decide what tests and what variables we need to focus on and what thresholds within those variables are most important. Because as I said, it's those combination of factors when we're changing direction or when we're landing, that control of anterior tibial translation that's going to load the ACL, and then in combination with either a knee valgus force or a position of a loss of center of mass control in the frontal plane relative to my stance leg, can very often lead to a combination of forces that can lead to an acute ACL rupture. So in our pathways in the sports surgery clinic, all our ACLs go through biomechanical analysis at various time points post reconstruction. Our testing protocol involves double and single leg counter movement jump for a measure of explosiveness, double and single leg drop jump as a measure of reactive strength, single leg hop for distance for horizontal force production, and planned and unplanned 90-degree change direction. And we also do isokinetic testing on the quadriceps and hamstrings as well, which obviously can have quite marked deficits after patellar tendon and hamstring tendon grafts. But ultimately, we're looking to analyze their movement strategies and trying to identify what are the differences between those that have successful outcome and don't. And if we begin with saying, when is an athlete fully rehabbed? Well, one of the things we can look at is when are they back to normal level of performance or levels of performance similar to someone that either has had no ACL injury before or the levels of performance relative to the non-operated knee. So in this study here, myself and my colleagues looked at a number of different jump tests at 9 months post-surgery in male athletes, a double and single leg drop jump, single leg hop for distance, and a hurdle hop. And we wanted to see at 9 months what biomechanical deficits were left between limbs at that point in time post-recovery. The first interesting stat was when we looked at the two single leg tests, so the single leg drop jump and the single leg hop for distance. And we found that commonly used metrics of or thresholds of 90 degrees or 90% of symmetry do not mean that you're passing all the tests concurrently. So as you'll see here, on average, the group passed the single leg hop for distance test, but they still had quite marked deficits in limb symmetry in the single leg drop jump, or in their reactive strength or plyometric ability. And there's been lots of literature, both systematic reviews and other studies currently, questioning the appropriateness of the single leg hop for distance as a measure of appropriateness for return to play after ACL reconstruction. There were, however, a number of biomechanical asymmetries that were consistent across all 4 of the jump tests. Those that had an ACL reconstruction had greater asymmetry in knee valgus moment, between knee rotation angle and ankle rotation moments. Those coupled frontal and transverse plane movements and forces at the knee and at the ankle. But they also had asymmetries in the sagittal plane with lower knee extension moments on the operated side. There was also differences in the ground reaction forces, or those sagittal plane differences between the double leg test and the single leg test. In the double leg test, because both feet were hitting the ground, there was more unweighting or greater weight put on the healthy non-operated side than the operated side. But in the single leg test, obviously that strategy is not available. So what the athletes did was they moved their center of mass more forward to reduce the knee moment, the extensor moment around the knee, thus compensating by changing the position of their center of mass. And this was quite consistent across the board. So at 9 months, we're seeing persistent frontal plane deficits in male athletes at 9 months post-surgery, deficits in reactive strength, but also deficits in the ability to absorb load in the sagittal plane. And that's illustrated by this video here. So when we have a look at this athlete, do a drop jump, you'll see that the green operated leg, as I play slowly here, when we look at the red arrow is the ground reaction force. You can see the red arrow is much higher, or they're loading their healthy red leg more than their operated green leg. What's also interesting is to look at the distance between the ground reaction force and the knee joint. So the ground reaction force sits well inside the knee, thus causing a varus force on the healthy knee. However, it sits very close to, or even outside, the operated knee, thus increasing the chances of having a valgus force and ultimately ending up in second ACL injury. Even though jump testing is probably the most common test used in ACL return to play decision making, almost 50% of ACL injuries occur during change direction. So we then went on to look at the same cohort and look at the biomechanical asymmetries at 9 months in planned and unplanned change direction. This is with a 5-meter run and a change direction left or right, either in a pre-planned motion or in reaction to speed gates, as demonstrated here. When we looked at the differences between legs in both planned and unplanned motions, it was interesting that there was the same asymmetries for both change direction tests. But what was also very interesting is there was no difference in time performance despite numerous biomechanical asymmetries. So the time to change direction left or the time to change direction right was no difference between limbs, despite the fact that there were a number of biomechanical asymmetries between limbs at 9 months post-surgery. And those differences, again, were very similar to the ones we saw in the jump tests, with asymmetries in knee valgus moment, rotation, ankle rotation, and knee rotation angles and moments, and knee rotation moment. Very similar to the jump tests and a throughout stance phase. And again, deficits in the sagittal plane with asymmetries in knee flexion angles. So on the operated side, they flexed their knee less, so they had a more extended knee position, and as a result had lower knee extension moments. However, we're all asymmetrical to a certain extent. So what variables or what tests were there asymmetries greater than healthy athletes who never had an ACL reconstruction? So we took these athletes that were male athletes that were 9 months post reconstruction, and we compared them to a matched cohort of healthy peers who had never had an ACL injury. And again, we looked at the differences across all the tests, both in performance variables and biomechanical variables. So again, when we look at the performance variables, it was interesting that there was very small effect size differences. So there was greater asymmetry in change direction in the ACL athletes than there was in the healthy athletes. Again, there was no difference in asymmetry in the single leg hop for distance between healthy athletes and injured athletes. But there was very large effect size differences in plyometric ability or in single leg drop jump height asymmetry between the two groups. So again, it seems to be a very, very persistent and large magnitude asymmetry in those at 9 months post ACL compared to those who have never had an ACL injury. And so where our research is taking us now is trying to use machine learning and artificial intelligence to try and look at the large data set we have of almost 1,000 ACL reconstructions per year over the last 5 to 7 years, and trying to identify at these various time points, can the machine learning processes identify whether you're a healthy athlete or someone that has ongoing deficits that would identify you as being an ACL reconstructed athlete. And my colleague Chris Richter is well published in the area and can find with almost 80% accuracy, he can identify if you're an ACL athlete or if you have the characteristics of a healthy athlete. And what's interesting in this is that much of the error in this comes from healthy athletes who are demonstrating characteristics of someone who has an ACL. So whether that's ongoing deficits they have from a different injury, or maybe someone that will go on to future injury, it's hard to tell, but certainly an interesting area going forward. However, the vast majority of us are interested in what about second ACL injury. And so we took a large cohort of athletes who went on to have a second injury and compared them to those who had no second injury after ACL reconstruction at 9 months. All of these were playing change direction field sports. They were all male athletes. We had 31 athletes who went on to re-rupture their operated knee and 55 who went on to rupture their previously healthy non-operated knee. We looked at isokinetic and jump and change direction performance tests and performance symmetry that's commonly used in return to play, but also looked at a number of biomechanical asymmetries. When we looked specifically at the differences between those who went on to re-rupture and those that didn't go on to re-rupture their operated knee, there was no difference on the ACL side in quadriceps strength, hamstring strength, hop for distance, counter movement jump, drop jump, or change direction time. So at 9 months, when we test these athletes, comparing operated side to operated side, and these performance measures could not identify differences. And similarly, there was no differences in limb symmetry index for all the same measures. So again, that's not that these variables are not important, but at 9 months, they're not able to identify who will go on to have a re-injury and who will not. Despite the absence of differences in limb symmetry or in comparing performance variables between operated leg and non-operated leg, and there were a number of biomechanical differences between groups. Those that went on to re-rupture their operated knee during the double leg drop jump had longer ground contact times, had greater knee flexion, and lowered their center of mass relative to the knee and to the ankle more. In addition, they had greater asymmetry during unplanned change direction. So those that went on to re-rupture their operated leg had greater asymmetry of trunk side flexion, greater asymmetry as a result of the distance between the center of mass and the knee and the ankle in the frontal plane, and greater pelvic tilt and pelvic drop. So again, these variables were not able to predict who would go on to second injury, but they had large effect size or medium effect size differences between those that went on to second injury and those that didn't, and would be worth targeting during your rehabilitation. However, there are other factors in relation to re-rupture, such as surgical technique, biological healing, graft type, etc., that may influence that. And those factors are less, if not irrelevant, when you're looking at contralateral ACL injury. So again, as I said, we had 55 athletes that went on to rupture their contralateral healthy limb within 2 years. So these studies were published at the beginning of this year in the American Journal of Sports Medicine. Again, we found no difference on the ACLR side when comparing hamstring strength, hop for distance length, counter movement jump height, and drop jump height and change direction time. And similarly, we found no difference in all the commonly used metrics for limb symmetry, which I suppose was counterproductive to my hypothesis, which would have been that the ACL limb is insufficiently rehabilitated. There are large asymmetries in these variables, and those asymmetries, put greater force or load onto the non-operated side, thus resulting in contralateral injury. However, that was not the case. One variable where there was a difference, even though a small effect size difference, is there was lower quadriceps strength on the non-operated side and those that went on to rupture their non-operated ACL. And again, we've often seen in the previous literature that the healthy limb can often decondition throughout the ACL rehabilitation process. So improving that quadriceps strength may be something that's important during that process. Despite the fact that there were no difference in many of the performance variables, there were a number of differences in the biomechanical variables. However, again, they were not in relation to asymmetry. When we compared the contralateral or the non-operated limb of those that went on to re-rupture to those that didn't go on to rupture that knee, those that had a second injury or went on to have rupture their contralateral limb had much different performance during the double and single leg drop jump. They had lower reactive strength index. In other words, they were less plyometric, and they had longer ground contact times. They had lower levels of center of mass stiffness. They flexed more at the trunk, hip, knee, and ankle, and as a result, then had different, in particular, reduced ankle plantar flexion moments that may influence the control of that anterior tibial translation. They also had a number of frontal plane deficits, in particular in the single leg drop jump, in relating to asymmetry of trunk side flexion and asymmetry of knee varus moment. So again, we're seeing this persistent deficits in frontal plane control, both in healthy athletes in ACL athletes compared to healthy athletes, but also in those that are going on to have second injury. But probably more striking is the persistent deficits in reactive strength, in plyometric ability, as a performance metric during biomechanical analysis, and of greatest interest when comparing those that go on to rupture their healthy limb compared to those that don't. So again, as I said, when we're looking at these factors of return to play and return to performance, and from a rehabilitation point of view, one of my greatest interests is in the absence of knee symptoms when they return, and obviously trying to minimize the risk of second ACL injury, both to the reconstructed knee, but also to the healthy knee. And so the physical tests are going to play a huge part in understanding their stages of rehabilitation and the remaining deficits. However, that's not to say that their sport-specific conditioning, their ability to tolerate the demands of their sport, and the skills execution is not important. We know, especially in terms of return to play, that social factors and psychological factors greatly influence the rate of return to play, especially outside of elite sport. And as I said, there are certain positions, let's say like goalkeeper compared to midfielder, where the injury risk profile may be different, but also the stages of remodeling, in particular the differences in remodeling speed between hamstring graft and patellar tendon graft, are factors that we must also consider. However, when we're looking to focus our rehabilitation, it's important to have measures of strength and explosive and reactive strength. However, symmetry of these measures may not tell the full picture of their rehabilitation status, and so layering biomechanical analysis of jumping and landing mechanics, of running and acceleration mechanics, in particular in the sagittal plane, where there's been a number of systematic reviews that shows reduced knee extension moment and reduced knee flexion angle during mid stance of running, and change direction mechanics as well, which obviously is an integral component of playing elite football, but also minimizing ACL re-injury risk. And that these combination of factors should leave us very well placed to make a successful return after ACL reconstruction, but also a sustained return to the field of play. So if you have any questions after this presentation, I'd be delighted to answer them. And I thank you very much for your time and attention. Thank you.